Follicular cysts arise in secondary follicles that fail to ovulate and may be single or multiple. Microscopically, follicular cysts have a thin wall lined with cuboidal or flattened granulosa cells, with an increased amount of follicular fluid and absence of an oocyte. Larger follicular cysts often have a thin fibrous outer layer. Follicle cysts arise from cystic enlargement of an ovarian follicle. They are usually unilateral, occur most frequently during the reproductive years, and may cause pelvic pain. Most regress spontaneously within a few months, but persistent cysts must be evaluated to exclude neoplasia. Their occasional detection in the fetus or newborn is attributed to maternal hormone stimulation. Aspirations from follicle cysts vary from sparsely cellular to exceedingly hypercellular. The background may be clean or hemorrhagic. The terms ovarian cyst and ovarian follicular cyst are often used interchangeably. These two terms describe lesions greater than 3 cm, and it is important to differentiate them from an ovarian follicle, which is less than 3 cm. They present in women of reproductive age. They are asymptomatic and frequently present on routine pelvic scans. They are a type of functional ovarian cyst and result from persistence of an unruptured Graafian follicle, which then becomes larger in size. They generally resolve spontaneously in 2 to 3 cycles. On ultrasound, they are 1. Thin-walled and unilocular. 2. Usually range around 3 to 8 cm in size. 3. By definition, if less than 3 cm, the cyst is termed an ovarian follicle rather than an ovarian follicular cyst. 4. There is typically posterior acoustic enhancement and an absence of internal echoes. 5. There should be no color flow, nodules, or any solid component. Differential diagnosis of follicle cysts includes 1. Epithelial cysts. 2. Simple cyst. 3. Serous cyst. 4. Mucinous cyst. 5. Endometriotic cyst. 6. Granulosa cell tumor. 7. Carcinoma. Follicle cysts can be a challenge to distinguish from cysts. When ciliated or mucinous epithelium is identified, the cyst is of surface epithelial origin and not a follicle cyst. Solitary follicular cysts are usually an incidental finding. When persistent, they may cause symptoms secondary to a pelvic mass and are typically excised to exclude malignancy. Acute abdominal pain secondary to torsion, with or without hemiperitoneum, may occur, particularly in neonates, although most follicular cysts that occur during the neonatal period regress within the first 6 months. Occasionally, follicular cysts may be associated with manifestations of excess estrogen production. Isosexual pseudoprecocity in children or irregular menses related to disordered proliferative endometrium and/or endometrial hyperplasia in women of reproductive age. Postpubertal women with cystic fibrosis may have a predisposition to developing solitary follicular cysts. Multiple follicular cysts are part of the spectrum of abnormalities seen in polycystic ovary syndrome, a common disorder characterized by hyperandrogenism of ovarian origin, resulting in virilization, infertility, obesity, and insulin resistance, Stein-Leventhal syndrome. Only up to 10% of women with polycystic ovaries have clinical manifestations. A family history is common, but the genetic factors in this disease are poorly understood. The most common etiology is insulin resistance of peripheral tissue and/or an abnormality of the hypothalamic pituitary ovarian axis. The findings of multiple ovarian cysts associated with cortical sclerosis, although part of the spectrum of polycystic ovarian syndrome, is not specific and can be seen in other causes of chronic anovulation. Therefore, clinical and biochemical assessment is required for this diagnosis. Solitary or multiple follicular cysts may also occur in association with McCune-Albright syndrome, polyostotic fibrous dysplasia, cutaneous melanin pigmentation, and endocrine organ hyperactivity, and in prepubertal patients with hypothyroidism. Cystic corpora lutea are a frequent finding in residual ovarian tissue in the setting of ovarian remnant syndrome. They may manifest as menstrual irregularities and rarely hematoperitoneum. Thanks for watching. Please subscribe for more educative contents. Tap like and also share to others for educative purposes. Thank you.